Welcome everyone to this amazing session. So the topic of today's discussion will be how to approach recurrent hypoglycemia in type 2 diabetes. Now, this is one topic which, trust me when I say this from clinical experience, there is this hypoglycemia, which is, I have written in the red color actually. This is something which many patients of diabetes, be type 1, type 2, any diabetic patient, is the one who is concerned about. So we will be focusing on the discussion how to prevent this recurrent hypoglycemia in the later part of discussion. But first, we will understand how and you can how to identify and what are the basic things which you will find in the patient, which you can estimate that he or she might land up into recurrent hypoglycemia. So let us begin. So the approach to the recurrent hypoglycemia, it is, I hope my pointer is okay. So why does hypoglycemia continue to occur despite newer therapies? A very excellent question. So I have written some pointers in each slide so that your thinking becomes active. So there are multiple therapies available now, and there is no one size fits all approach. Every patient has his or her needs, be it age, be it financials, or be it the long standing diabetes. So despite of the latest technologies, latest therapies, still there are patients who are suffering from hypoglycemia, and that too recurrent. So we need to have a look at that. Then the practical outpatient approach for the physicians. So as you all are doctors, or mostly who are attending this, so I will be giving you some key pointers which will be in the form of clinical pearls, which you can actually utilize in your daily practice to find out such problematic areas where you can avoid hypoglycemia just by awareness by yourself, and also creating awareness to the patient. And then we will understand the prevention, diagnosis, treatment, and long term management of this recurrent hypoglycemia. So let us dive in. So why this hypoglycemia matters? That's a big question. Why we are actually talking about this in nutshell? Diabetes is hyperglycemia. So why even are we talking about this hypoglycemia? See, hypoglycemia, as you might be aware, it is more dangerous than hyperglycemia. Why so? Because it is associated with falls. Okay, the patient may actually fall down suddenly while working. He or she may fall down, especially the elderly diabetics. It can lead to fractures. So imagine a person who is a hypoglycemic, who is having a hypoglycemic episode. He or she is bathing, and or supposedly he or she is just alone in his her house. So you can imagine this can simply lead to fractures, especially the pelvic fractures, and those can be bigger problems. So hypoglycemia is such a big problem which can cause multiple small issues which you even can't imagine. So you have to consider it as the utmost priority when you're dealing with a diabetic patient. And as you might be knowing, the cardiovascular events. So as you understand, hypoglycemia means there will be less glucose. So when the blood sugar level is down below the normal limits, so it will lead to multiple events. There can be cardiovascular events or cerebrovascular events or any kind of such events which can be fatal also, and eventually that would require hospitalization. So this also creates a fear of treatment and poor adherence amongst the patients. This is very important. You have to understand this. So severe episodes, they increase the mortality risk. Suppose if there's a patient you encounter today who is having hypoglycemia, let's say once in a week or once in a month, that he or she may not be having any major problems. But suppose if there are severe episodes beyond, the sugar is dropping down beyond 40, less than 40 or less than 50, and that is happening multiple times, maybe in a week he or she is experiencing twice or thrice and even more. So then this will drastically increase the mortality risk, and that will be a problem to the patient. So I have written some clinical pearl in the lowest corner of this slide, if you can read. So patients fear hypoglycemia more than hyperglycemia. So this is a very important point again. Patients nowadays, when you have chat gpt and you have all the AI tools, so patients are more aware. Okay, so they already know what is hypoglycemia, what is hyperglycemia. So they do fear about this hypo because they don't feel any major problem when they are having hyperglycemic, but they do feel problem in their work. See, when the patient is having the hampering of his or her activity, day to day activity, then he or she will be, problematic, then he or she will land up to visit a hospital, and that is where the hypoglycemia comes into picture. So now focus on this table. I hope this table is very useful. Please give a thumbs up or a heart or a smiley if your guys are listening. So this hypoglycemia flow chart, or I can say the definition and the classification, is something which most of us are not aware. And this is something which you have to educate the patient also when you are starting a treatment. So hypoglycemia alert value, that is when to take action, that is below 70 milligram per deciliter. Please remember, the normal blood glucose level begins from 70 to 110. That is the normal fasting blood glucose level. So if the fasting in the morning, if the patient checks the fasting blood glucose and that value dips down below 70, then it's a hypoglycemic episode. But nowadays patient will approach you, he or she will say, sir, I am having 75 level, so I am having hypoglycemia, and he or she may not have any problem as such, and next day you will check, he will say that he's having 90. So that's not a problem. But yes, your treatment has to be modified. You cannot keep it around 70. That is not safe zone for any patient, especially the elderly, when you have higher cutoff ranges for the HbA1c. So clinically significant hypoglycemia, when is that? So it is below 54. Please remember, this is a red alarm. Okay. So if you notice the patient is messaging you or telling you, sir, my sugar is below 54, so then it's an alarming situation for the patient. And then there's third level. So there are level 1, level 2, level 3. Okay. So third level, level 3, is severe hypoglycemia. Now severe hypoglycemia simply means where the sugar reading is below 54, beyond 40. So there's no cutoff as such. So even around 40, around 30, then it's a severe hypoglycemia. So no specific glucose threshold value is depicted in the standard guidelines. So it is associated with severe cognitive impairment requiring external assistance for recovery. Now this is very important, and usually when you find such level 3 patients, they are in a hospital setup, and that is the place, that is a time when the patient requires some intervention, maybe intravenous injections. We'll talk about that in a while. So now how to identify? You should be also aware. So what are the common symptoms you will notice in the patient? See, many patients always keep on telling these symptoms, but as a doctor, you sometimes you ignore these symptoms, that okay, this is normal, this is not normal. You have to be alarmed when the patient is focusing and telling you about these symptoms. So please pay attention. There is autonomic symptoms like the sweating, tremors. I know these symptoms can overlap. There can be other disorders, diseases with these symptoms, but I'm focusing right now on hypoglycemia. So sweating, tremors, and palpitations. Now palpitations, as you know, it can be simply due to multiple issues also. A simple gastric upset can also cause such of the problems. But yes, you have to rule out with the history, proper history taking. And hunger. Very important point, the first one which I have written here, neuroglycopenic symptoms, which includes the confusion. Now please remember, confusion is something which you will notice, and the patient may also complain of blurred vision. Now this is something which I have seen in the patients reporting to me for hypoglycemia episodes. So blurred vision is something which you have to actively ask. Sometimes the patient does not reveal these symptoms, so you have to be proactive in asking these. Then drowsiness, the patient will definitely tell you. Behavioral changes can happen. So why recurrent hypoglycemia happens? So now understand the why behind the thing, because now we know what will happen, how it will happen. So what will be the levels now, so why this is happening. This is the, I would say, the guys who are actually looking at this presentation, please take a note of this slide. This is the most important slide of today's discussion, because if you don't know why, then you cannot actually identify or diagnose hypoglycemia in the patients. So number one, and the root cause of hypoglycemia, I would say, in today's world, is excess medication. What happens? It's actually due to both sides, due to the doctor side as well as due to the patient side. What happens? Usually the patients tend to do doctor shopping. I hope you know what is doctor shopping. That means patient visit one doctor, they feel less satisfied, they take second opinion, and then third opinion, fourth opinion. They keep on checking the multiple doctors that what is best treatment for me, because sometimes they feel that maybe there is some alternative option available, and most of the times they avoid medication. So the number one cause is the excess medication. So Dr. A will prescribe some medicine, Dr. B will add on to it, Dr. C may not look at the first prescriptions, and ultimately the patient lands up taking excess medications. But another case scenario, many doctors actually add medicines on call, or on phone call or on discussion with less, if there is a busy OPD, they add they add uh, the medicines. So now what happens? So this patient is not aware which previous medicines he has to stop taking. So that creates a loophole in the communication between the doctor and the patient. So please remember, as all the doctors who are listening to me, please make sure that you ask the patient, be takes let it take time when you are consulting the patient, that what all medicines you are currently taking, and ask homeopathic, ayurvedic alternative options also. Maybe the patient is not taking allopathic medicines at all, and he's taking other medicines, he may hide from you. Then reduce food intake. This is a big problem, especially in the elderly and especially in the middle aged parents. Okay, so the patients, they are prescribed medicines to the full scale, and they do take sometimes food, but they sometimes miss the food also. You might have seen your parents may say ki, today I'm not feeling like eating dinner, so but he or she will take the medicine, and what will happen? There will be the hypoglycemia. So you have to be aware that reduced food intake is some element, especially in the dinner time, which you have to make sure, and take history, whether the patient or his relative is reporting actively, sir, he is not taking meals properly. So that's a very important history. You have to focus on that history. So I'm spending maximum time on this slide because this is the most important slide, as I told you previously. If you guys are listening and you feel that this is the most important slide, please give a thumbs up or a smiley if you also agree with me, because this is the root cause of today's problem. Then increased activity. Now patient is having increase in the physical activity, and what happens, he is having recurrent hypoglycemic episodes. Then there can be underlying renal or hepatic dysfunction. So how will you identify that? You will identify that with the help of simple blood test, simple investigation. So your job, as when you are consulting the patient, please make sure, ask him, do you have any blood test in the last 6 months or 1 year? Don't force the investigation as such directly. He or she will think that, please sir, I'm already, I don't want to spend too much money on the blood test. So at that time, you have to please ask that if in the last 1 year or 6 months he has undergone any LFT, KFT, lipid or any kind of test, please have a look at those reports. And if you find some fishy numbers, then repeat the test immediately. Alcohol use, I think most of you are aware, that is the biggest problem. Then unrecognized hypoglycemia. Patient is having hypoglycemic episodes, but he's not aware of it. So I will talk about that unawareness in the eventual slides. But this is something which, again, as a doctor, you have to make sure you ask the patient. Then what are the drugs most commonly responsible? I think most of us will agree that sulfonylureas remains the highest risk category. Yes, please give a thumbs up if you all agree with this. And this is one area which I think most of the doctors are worried in prescribing sulfonylureas. You avoid sulfonylureas so that the patient does not land up into hypoglycemia. So why does it happen? If you remember, the sulfonylureas, they keep on stimulating the pancreas to release insulin. So that is the big problem to the patient. So suppose if the patient takes Emeril 1 mg or 2 mg in the morning, early morning, and he does not consume any food, maybe he skips breakfast, he's a working professional, or in the elderly, he does not feel like eating in the morning. So it will happen at around 10 or 11 in the morning, he will have severe hypoglycemia, and especially in the surgery phases. So when the patient is posted for surgery, so then to definitely have to avoid sulfonylureas. You can continue other medicines, obviously with proper discussion and documentation, but sulfonylureas, you have to be very particular. You cannot afford to give the patient when you are feeling that there are multiple high risk episodes of hypoglycemias. Then the insulin. Now, insulin, as you know, there are multiple, types of insulins. So the long-acting insulins, if you know the glargine and all, those will never cause hypoglycemia, as you are aware. The simple insulins, which you know, the regular insulin, if the patient, nowadays patients are very smart, they will, manipulate the insulin readings by themselves. They will not visit the doctor. Okay, they will manipulate them, and without any understanding, they will take high dose of insulin at the wrong point of time, and that will put them at a higher risk for the hypoglycemia. So please make sure you take proper history, that if the patient is on insulin, then when or at what time he or she is taking the insulin, number one. Number two, whether he or she is manipulating the values by herself or himself. Then moderate to low risk, see, metformin is completely safe. Okay, it's not the biggest cause of hypoglycemia, but yes, you have to be wary of this medicine also. Even the DPP-4 inhibitors, along with the SGLT2 inhibitors, along with the GLP-1 RA, the receptor agonist. So all these, as you know, these GLP-1 RAs and all these newer treatments, they are good, no doubt. They will not cause severe hypoglycemic episodes, but understand one very important fact. I don't know how many of you are aware of this, that patient may be taking SGLT2 inhibitors, or let's say DPP-4 inhibitors, but he forgets to tell you that he has also been prescribed sulfonylureas. So that is the loophole in the communication. Many doctors, many patients do miss to discuss this. I have seen multiple cases. And so please remember, you have to remember the highest risk case scenarios. And when you are seeing on the prescription the patient is taking some metformin combinations, please ask very clearly multiple times, if you have to, that are you taking other forms of insulin or sulfonylureas. The best catch point to ask the patient is that whatever medicine he or she mentions, please ask immediately, since when are you taking this medicine. So most of the times the patient will tell you, sir, this medicine has been prescribed only since 1 month. So then you will think, 1 month, then what were you taking 1 month before? Sir, I was taking this XYZ medicine and then maybe sulfonylureas. Then he will tell you, sir, that also I'm taking, I have not stopped that medicine. So that thing you have to catch. Okay, so these are very small practical tips which I'm giving. Maybe it's helpful for the audience. If yes, you can give a thumbs up. So whenever the recurrent hypoglycemia occurs, first review insulin and sulfonylurea. So that's the clinical pearl take home message. If you don't want to listen to my all whatever I'm telling you, the nutshell statement is given in the last. Okay, so you can revise through these slides also. So next, the typical OPD patient. Now, most common scenarios, as I have discussed most of them, elderly patients on premix insulin. So there can be severe cases where you will find elderly patients are the most common age group which are at risk of recurrent hypoglycemia in type 2. I'm talking about type 2. So there are multiple reasons to it. Number one, premix insulin. Again, you have to adjust the doses and you have to ask the patient what all doses he or she is taking. See, again, I'm telling you this point, that premix insulin the patient is prescribed from one doctor, then he does not visit that doctor for 2 years or 3 years. He thinks that I am the doctor, and he takes the dosage in its own control, and then he manages and he sees the results also. He's able to control the blood sugar, but what he misses is the hypoglycemia episodes. In the morning he gets 70 blood sugar, he's okay. He gets 75, he's okay, he does not feel any problem. But when immediately when the sugar level drops beyond 70, then he has problem. Then he lands up into the typical OPD to the doctor, and then he is told about all these things. Then the CKD patient, the chronic kidney disease patient, especially on sulfonylureas. So please remember to check the kidney function test. Do not miss this by any chance, whatever practice you are doing in whatever specialty. If you see a diabetic patient in your entire life, even after MBBS, as an MBBS doctor, please remember to find the CKD patients. And the increasing creatinine values, urea creatinine values, is the most basic thing which you can catch. Okay, obviously if you feel that you are not able to treat that patient properly, you can always refer to the super specialist. So then I told you previously, missed meals. So patient misses the meals, especially I'm telling you in the fasting. So there is Navaratri fast or Ramzan or any kind of fasting the patient is doing as per his religion. So the patient misses the meals, and he takes the insulin. So there creates a loophole. The patient has to be told and explained about everything, that whether or not he or she should fast, and if yes, then how he or she has to manage that fasting period, and how to overcome the hypoglycemia or even the hyperglycemia. Then again, something which I think most of the doctors who are here listening, we have more than 250 doctors listening to me right now, overly aggressive HbA1c targets. So I think most of us will agree, HbA1c patient and doctor both are concerned. But you have to remember, it's not a simple mathematics, it's dynamic. So you have to focus on the HbA1c value based on the age group. If it's an elderly patient, do not make strict guidelines. No, I have to keep HbA1c below 5.5. No, it is not going to happen. You will land up into recurrent hypoglycemic episodes. The patient will be problematic. So what you have to do, you have to maintain the HbA1c targets as per the patient's needs. So for example, if there is an elderly patient, I'm giving a very famous and a very crude example. Suppose if you have a patient who is 60 plus age, okay, and you are targeting, you are controlling his, managing his blood sugar, managing all his medications, maybe insulin also. Please maintain the HbA1c target below 7.0. Okay, around 7.0 is safest range in the elderly patient. Around 70 also same targets. So that way you do not risk any hypoglycemic episodes. Okay, so you can afford to have the sugar ranging around 110, 120, 130. That's okay. But do not have a range around 70. That will be a problem to the patient. Sometimes he will miss the meals, sometimes he will have some other problems, and maybe sometimes what happens, the patient while taking the insulin, he or she does not follow the proper dosage. He thinks that he is taking 34 units, but while dialing the dosage in the insulin pen, he dials 40 units. It has happened. I've seen multiple patients having different readings while they're entering. So it's not so easy or simple thing that okay, this is stupidity. But no, patients do it unknowingly. So please remember, you have to have some buffer for the blood sugar levels. You cannot be very strict in managing. But yes, if you have any chronic infections, suppose a diabetic wound or something, then you have to be very much actively checking the blood sugar. Then you cannot afford to have high blood sugars, otherwise wound healing will not happen. Then high risk groups. So I think most of us, we have understood this. We have this is an overlap between the previous slides, but this is a separate heading, so I've taken it separately. So age is more than 65, as I told you, that's the highest risk age group. Then CKD patients, long duration of diabetes, especially see, long duration of diabetes patients are masters of diabetes. So whatever you tell them, they will always think that they know more than the doctor. Okay, and if you try to contradict them, they will maybe they will think that you are not the correct doctor to discuss with. So you have to be on the same page with the patient, see what his needs and understandings, what he wants to know. Whenever the patient reaches you in the OPD, please, in the first 20 seconds, understand what he's wanting to know from you. If you catch that point, your practice will be good, and you will be able to help the patient in the nutshell. But what happens, you don't listen. Usually we miss the point. We try to tell our own advices, and that usually the patient is not interested in listening. So please first address the patient's concerns, and then you look at the things. So now, long duration of diabetes, the patients are masters. So they know all the treatments, they know all the insulin types, they know everything. I'm talking about the some group of patients who you have to deal with differently. So long duration of diabetes patients are the highest age groups, the highest risk groups. Then cognitive impairment, as I discussed, that if there is recurrent hypoglycemic episodes, there will be cognitive impairment. Prior severe hypoglycemic episodes, that can also predispose to the future hypoglycemic episodes. Then, as you know, living alone. So living alone itself is a big problem for the elderly age group. As you know, the usual case scenario, the patients are unable to manage their blood sugar. Many of them are not able to test the blood sugar through the strips, and some of them, they are not able to inject the insulin themselves. So those patients are at high risk because they cannot manage the hypoglycemia also at home. So one statement, clinical pearl for all my fellow doctors who are listening to me: older adults require individualized glycemic targets. So this is one take home from this slide which you have to remember. I hope you all agree. Please give a thumbs up or anything. Then, as I told you, I was going to discuss hypoglycemia unawareness. So, patient loses the warning systems. So, warning symptoms. So, what happens? The hypoglycemia unawareness. Please remember, the patient is not aware, but he or she is experiencing hypoglycemia multiple times. So, warning symptoms, patient is unaware of them. So maybe he is experiencing, but he's thinking, Nani sir, that is not due to hypoglycemia. I am suffering due to something else, and he blames some other cause. And when you ask the patient actively, did you check your blood sugar? No, sir, I don't think it was necessary. So I did not check. So that is the lacuna. As a doctor, also, you can't do anything because the patient has not checked that time, the sugar levels. So you have to make sure you alert the patient that if there is, when you are prescribing sulfonylureas, insulin, so you have to tell the patient, please keep a check of blood sugar. I always have a practice to give up, blood sugar charting. I can share with you guys. If you want to ask me, I will share with you, any one of you. So there is a blood sugar charting method which you can give to the patient for any time whenever you are making a change in the treatment plan, so that you don't miss this hypoglycemia and hyperglycemias. Then the patient often presents directly with neuroglycopenia symptoms, so which we discussed previously, confusion and all those. So the patients can directly present to you with this, and you don't know the patient's diabetic status. So you have to think that maybe he is having hypoglycemia. I know there can be other overlapping disorders, diseases also, but this is one thing which you have to not miss. Strong predictor of severe episodes. So this is again a very important point. So ask, do you always feel symptoms before sugar falls? So you have to ask this to the patient, so that you can catch hold of the important history which you may be missing. Then stepwise evaluation of recurrent episodes. Now, as a doctor, you have to, or maybe your clinic staff, you have to advise them. If you have a high rush OPD, you have to mention to ask the patient about all these questions. There may be multiple other questions, but these are must ask questions. Number one, when does it occur? Ask the duration. So duration and timing and is very important. You have to ask the patient whether it happens in the night, whether it happens in the morning or in the afternoon, especially after the meal, before the meal, with respect to the insulin, before insulin, after insulin. You have to ask everything in detail. That will give you an understanding when you have to control the dosage of the previous medication, so that you can avoid such hypoglycemic episodes. Then what medication is being used? As I told you already, sulfonylureas, insulin, all those we have discussed. Any missed meals, already talked about. Any exercise pattern, maybe the patient is having strenuous activities, or maybe he is practicing high exercise activities which you are not aware, so you have to ask everything. Then any renal dysfunction, that you can simply catch hold with the help of latest blood test reports, maybe within the less than 6 months. That is the ideal case scenario. Then, if we talk about the pattern recognition, now this is again a very important slide. So, pattern is the one thing which you can guess. So, like a Sherlock Holmes, so you have to be Sherlock Holmes to ask the patient the relevant questions to catch hold of this pattern of hypoglycemia. The doctor who can catch these patterns very easily and very fast and early, so you can save the life of the patient, plus your practice will also bloom. So fasting hypoglycemia, this is something which you have to ask first. See, there is a thumb rule of diabetes treatment. I hope many of the doctors will agree. There is simple thumb rule, that is fix fasting first. I repeat, fix fasting first. I hope most of you will agree with this. So in all the patients, in all the treatment regimes, newer, older therapies, as everyone is treating the diabetic patients, you have to fix the fasting blood glucose first. Once you are able to do that, then you are able to definitely you will be able to catch hold of other problems. Because suppose I give you a simple example, maybe some people are maybe thinking why I'm saying this statement. Suppose if you are focusing more on postprandial blood sugar, then how can you even control the postprandial if the fasting is ranging between 250 or 300? You cannot do that. So it's a thumb rule of every diabetic treatment. First you have to fix. Now suppose if you are fixing, you have listened to my talk, you're fixing the fasting hypoglycemia first, oh sorry, fasting blood sugar first, but you fix it too much, over fixation. So what will happen? You will land the patient into fasting hypoglycemia. So patient will wake up with very low blood sugar on every day. So don't do that. Okay, so you have to be a little bit loose but not too much tight, so that you have to maintain the treatment regime that way. And a best approach which I follow myself, I'm telling you, I'm sharing with you, whenever you're making a change in the patient's treatment regime, inform the patient. The best thing is communication. Inform the patient ki I am changing your medicine from A to B. There may be a chance the blood sugar will remain a little bit high. Don't worry, don't panic. Please keep on blood sugar charting, and visit me again or share the blood sugar charting after a week. If that chart seems to be having no control, I will upscale or up titrate the dosage a little bit. Make this informed to the patient early. Otherwise, what he will do, he will take the treatment from you, he will visit another doctor after 3 days. Sir, I visited falana doctor and he gave the treatment, it's not working, sugar is high. Then the patient will see, ultimately what is happening, you are losing the patient, that is another thing, but the patient is landing into hypoglycemia because the second doctor will over prescribe the medicine, because the first medicine does not seem to work. So that is a very big lacuna in the communication which you have to avoid. So I hope this is informative for all of you. I'm sharing some practical tips also which I have gained over past many years, so maybe that helps multiple doctors who are listening to me. You can write in the comments box if the session till now, we are almost till the mid of this session, I hope it has been useful to you. You can write the flood the comment box with the same. It will be a motivation, I will add more value to your lives. So fasting hypoglycemia. Now fasting hypoglycemia we have discussed. Then excess basal insulin. See, basal insulin and bolus insulin, you are all aware of the regimes, but basal insulin also has to be used judiciously. You cannot think that okay, glargine will never cause any problem. It's not like that. You have to make sure that you up titrate the dosage very slowly. The classical scale which usually the doctors follow is to increase 2 units every 3 days, not before that, if you are up titrating and checking the blood sugar simultaneously. Then sulfonylureas we have discussed only, CKD we have discussed. Postprandial hypoglycemia. Now postprandial hypoglycemia means, simply just imagine the patient comes to you, sir, I have checked my blood sugar after the meals and that is coming around, sir, 100, okay, or maybe it is coming around 90. So you think that it's okay? Please ask the patient at what time did he check. Okay, so maybe usually the patients check the blood sugar postprandial, they don't usually understand, and doctors fail to communicate this to the patient, that it is 2 hours postprandial, means post meals 2 hours. Please remember 2 hours is very important. So they can have postprandial hypoglycemia also. So if this is happening, so there is some problem with your treatment regime. Maybe your insulin timing and dosage is not proper, or maybe your medicine dosage and timing. See, all the OHA, oral hypoglycemic agents, whatever you prescribe to the patients, they have to be given at certain points with respect to the meals. It's not a blanket treatment ki take anytime any medicine. It's not like that. You have to focus and tell to the patient that when you are prescribing, it has precise limits, 30 minutes, 15 minutes, or after meals, with meals. You have to be very precise in telling to the patient. Otherwise, number one, he or she will not be able to control the sugar, number one. Number two, even if he controls, he will land up into hypoglycemia. Excess bolus insulin, that is also an issue. I discussed excess basal as well as bolus, both are problematic. Then meal mismatch, as I told you, it's an overlapping point between the previous points. So meals mismatch meals mismatch simply means that the patient is not taking the medication with respect to the meals, or the patient was prescribed to take the medicine or the insulin dosage before the meals, let's say at morning 10 a.m. supposedly you prescribe, but the patient is taking breakfast at 2 p.m. because he's waking up at 12 p.m. So you have to ask the patient, take the history properly, sir, when are you waking up, when are you taking the morning dosage. You have to ask everything, because many times I have seen the patients are working professionals and many times they have night duties. So what do? They will wake up late in the morning, they wake up at 12 maybe. And then suppose if someone is working for a US company, so he or she will wake up at 12 only, then when will he take the medicines, insulin, everything? So there will be a meal mismatch. So please ask the patients all this history, and the best doctor will be the one who will be able to recognize these patterns at the earliest. So my fellow doctors who are there, I think we have more than 300 participants right now. I hope you all will be able to recognize the pattern after today's discussion. Please give a thumbs up if you feel confident enough by today's discussion that maybe 0.01% you will be better be able to recognize the pattern in the next consultations. So then we talk about the lab investigations. So this is, see, one thing, this lab investigations are always secondary. As I told, don't jump to the lab test always to the patient may think that doctor is always prescribing the test only. Ask the patient first question, sir, whether do you have any report less than 6 months old? Then he says yes, please don't prescribe the test if it is not necessary. But if yes, if it is definitely essential, then go for the recurrent HbA1c values, renal function, liver function, thyroid profile, and also review the medications. Please remember, review all the medications, do not miss. Sometimes the patient hides the prescriptions, old prescriptions the patient does not have access to, and he's still following those medicines. So don't hurry in the consultation. Tell to the patient, don't worry, I am with you, please go to your home and then fetch those records and share with me on WhatsApp. That way the patient will be calm and not he will not say that, sir, I don't remember you prescribe any medicine. That way you will not miss important pointers. So please ask the patient to share the current and previous prescription at all times without any no negotiation on this. Then you might have heard of this CGM devices. Yes, there is continuous glucose monitoring devices. So it detects nocturnal hypoglycemia. See, it's a costly device to the patient. You have to see the pocket also of the patient. So don't be heavy on the pockets to all the patients. It's not a good thing to do. Okay, so detects the nocturnal hypoglycemia, we all know, but please make sure prescribe CGM devices only to the patients who actually need it. Don't just give a blanket that please go for CGM devices. And some people, they take CGM devices by themselves even if you have not advised. So please make an active decision ki tell the patient you don't need the CGM device. Okay, so don't unnecessarily advise the patient or avoid giving the CGM if it is not required. Very important point. But suppose if the CGM device is there and the patient is affording this device, it will help to detect nocturnal hypoglycemia, and that's a very important thing. Suppose if you don't have access to CGM, how will you identify the nocturnal hypoglycemia? Ask the patient or its relatives to keep an alarm at 3 a.m. in the night and check the blood sugar for consecutive 3 nights. That way you will have a good estimate whether every day he is having. See, one single reading does not mean anything. Okay, be it fasting, be it midnight reading, anything. For one reading is never useful. You have to take a series of readings in all the diabetic patients. Identify the asymptomatic episodes. Okay, so ask the patient whether he had the hypoglycemic episodes. You will see in the CGM devices. See, there is a digital format which you get this kind of graph. Okay, like the picture represents. You get a mobile graph available which the patient can share with the doctor very easily in the application. So using that, you can ask the patient when there was a dip in the blood sugar level. You can ask whether he was symptomatic or not. That will also give you again a hint at pattern recognition. Allow for the therapy adjustment. So please make sure you adjust the therapy accordingly. Recommend increasingly for the hypoglycemia prevention. So when you are seeing a patient who has recurrent multiple episodes of hypoglycemia, even on doing everything, taking the treatment or everything, still the patient is experiencing hypoglycemia multiple times, then what you will do? Then you will definitely recommend him to take a CGM. Suppose if he is not able to purchase, advise him for few days or maybe few 1 week or so that you can monitor very easily. So one line clinical pearl for all my fellow doctors here: CGM often reveals far more hypoglycemia than patients reports. So this is one clinical pearl for all the doctors. So nocturnal hypoglycemia, the hidden problem. This again one thing which you have to make sure you identify very early. Patient can experience morning headaches. Ask, if the patient is not telling, ask actively whether the patient is experiencing morning headaches. Ask whether he is having night sweats, or even the patient is not telling you, ask the relative whether he or she has the night sweats. This is a very important history. Usually the husband and wife sleeping together, they can tell ki sir, I saw him in the middle of the night, he was having severe sweating but he was sleeping peacefully. So then also it's an alarm. So you have to make sure pick out all these things, otherwise you will miss hypoglycemia. Hypoglycemia is not easy to pick, trust me. So poor sleep, patients are having poor sleep, and that also is a problem to the patients, and that can also lead to hypoglycemia. Unexplained fasting glucose variability. Some days the fasting glucose is coming 60, some days it's coming let's say 120 or 130. All of a sudden it is jumping from extreme values between daily, not over a week, but daily it is dipping and coming rise. So you have to understand and dig in the history to ask the patient about and understand in detail why there is unexplained fasting glucose variability. It should not happen. And I tell you one more thing from practical experience, maybe many patients or many doctors will agree with me, that you asked everything to the patient, everything seems to be perfect, you're not able to find any pattern, but still the patient is experiencing hypoglycemia and asymptomatic. So there can be a simple problem, the glucose monitor can be a problem. So this also you have to ask the patient that please check the monitor also by using the same monitor for the different family member and check the blood sugar. Maybe sometimes you will notice that hyperglycemia is seen or hypoglycemia is seen wrongly in the glucometer, or maybe the patient's testing method is wrong, or maybe the test strips are expired. That is the most common case scenario in India. So please make sure you have to remember these few points. These are all practical tips, you will not find them in textbooks. So these are all practical tips which you have to make awareness in your mind so that you ask the patient actively. I hope most of you will agree. Please give a thumbs up or a heart or a smiley, anything, so that it keeps the motivation high of the talk. Okay, so then acute management. So now we know the problem, we know the why of the problem, we know what how to identify the problem. So now let us manage the problem. We are moving in quite sequence. So now if there is a conscious patient is conscious, you are having hypoglycemic episode, simply advise the patient to take 15 gram of fasting fast carbohydrate. Okay, so the patient can take carbohydrate in any form. Okay, then recheck after 15 minutes. Please remember, recheck after 15 minutes is a very important thing. Otherwise you will not come to know whether the level has risen or not, and advise the patient. Usually you don't advise the patient and this is missed. Then in unconscious patient, so definitely you will go for glucagon and IV dextrose injections. Okay, then treat the glucose less than or equal to 70 milligram per deciliter promptly using fast acting carbohydrates. So if you notice that it is gradually declining, or if you notice the first reading 70, other reading 65, you see that the patient is landing up into hypoglycemia, especially in a hospital setup. So please make sure you give the advice treatment. Treatment modification in the OPD basis you can do. Reduce the insulin dosage. I think you know better. When to reduce is most important. Reducing, everyone knows, even the patient knows that he has to take less insulin dosage. But you as a doctor, you have to advise carefully, very clearly, that when to reduce the dosage and which insulin has to be reduced to prevent the hypoglycemia episode later on. Stop or reduce sulfonylureas, you have discussed that. Switch to agents with lower hypoglycemia risk, like metformin is completely safe, glargine is completely safe, no risk of hypoglycemia. I think most of us will agree with this. Relax the HbA1c targets when appropriate. As I told you previously also, for the elderly, please make sure, all the fellow doctors, that you have an target HbA1c at 7. Okay, do not go beyond this level. Supposedly if there is active infection or wound, then you have to go obviously, but otherwise if there's no exceptional cases, then please keep it around 6.5 or 7. That is the safest range to keep for the long term control. Then prevention strategies we have discussed: structured patient education, Meal planning, you can advise, you can refer to the dietologist if you think that dietitian, sorry, if you can if you think that diet is the main problem, so you can refer to the dietitian. Then you can go for CGM devices, I told you. Sick day rules, that is followed, and then carry glucose at all times. So those are prevention strategies which you can advise. So please remember, most recurrent hypoglycemia is preventable. So practical take home algorithm for today's session, that is, if you notice recurrent hypoglycemia, first confirm the episode. Maybe it is not a hypoglycemic episode, it's something else. Review the medication if you noticed, and I told you how to review. Assess the meal pattern, advise to the dietitian if required. Check kidney function properly monthly, or sorry, if you want to check it 6 monthly or annually, that's okay, but please check it. Consider CGM devices monitoring if you notice that recurrent hypoglycemia risk is there. Modify therapy, review medication, same thing. Educate the patient. Very important. Please spend some 5 to 10 minutes of your life to educate the patient in detail about whatever is happening with him and advise him the appropriate steps. Your 5 to 10 minutes of help to the patient will actually save his or her life in the need of the hour. So last, for all my fellow doctors, we have more than 320 doctors listening to me right now. I am also happy to do that. So I'm thankful for the Medflix, app to give me such a platform. So 5 clinical pearls which you can find, all doctors can agree with me. Sulfonylureas remain a leading cause, number one. These are the take home 5 clinical pearls which you have to remember. CKD magnifies the hypoglycemia risk. I hope everyone will agree. Nocturnal episodes are frequently missed. We have discussed in detail. CGM changes the management. That also we have discussed in detail. Every level 2, level 3, I think now you know level 1, 2, 3 of hypoglycemia levels. And this deserves the intervention. Very important. So that's it from my side. Thank you all. And you can follow my Instagram handle, that is dr.nikhil.md.kgmu. You can go for the Instagram profile, and I think I can see most of the doctors. So please make sure you follow my profile. I do teach AI healthcare, and I teach human anatomy also. I teach multiple other aspects of your life. Simple awareness programs also. I do multiple sessions at various places. I try to, be omnipresent in all the spheres of a doctor's life. So please follow my profile for regular updates, and you can connect with me and ask any your queries right now. So now over to you, Dr. Sanika. Your audio is gone. I am not here able to hear you. You're on mute, I think.
Can you hear me now?
Yes. Can we keep the slide, that last slide, in the view? Is it possible to keep that?
We'll
Simul-
take the questions, sir. We'll have the questions. After that, I can share that slide.
okay, sure. Please go ahead.
Yes. Yes. All right. So we've received a couple of questions, and I was saying when I was muted is that the reactions speak for themselves.
Okay.
The session was very well received. I'll
Thank you
take
so
a
much.
couple of questions, sir.
Thank you so much. Yeah.
Uh, Sir, in which group of patients are more prone to hypoglycemic episodes? Is it the type 1 or type 2 diabetes? And
Okay.
why? Or either?
Okay. Okay. See, the point is that both type 1, type 2, any kind of diabetic patient is prone to hypoglycemic episode. It's not that only type 2 diabetes. Today's talk was focused on type 2, so we discussed more on that. But type 1 is definitely more prone for hypoglycemic episode because they are primarily on insulin only. And that depends upon what insulin they are taking. If they're managing the blood glucose properly, then the hypoglycemia episodes will not occur. But especially in the diabetic elderly patients with type 2 diabetes and type 1 diabetes with early phase of type 1 where they don't know about their management protocols, these are the two most common prone age groups or patient groups which can have hypoglycemic episode. I think Dr. Ravindra, your query is sorted.
Yes, sir. Another query here is about the pathophysiology that during an hypoglycemia episode, we experience profuse sweating, tremors, and palpitation. So, what would be the reason for this?
Okay, see, it totally depends upon the level. See, blood glucose is the main thing in the body. It is, taking care of all the simple functions of the body. If that glucose level drops beyond the permissible, beyond the normal limits. So patients, all these symptoms will be evident, like sweating or the tremors, palpitation. And please remember that these symptoms may be either one symptom may persist or maybe all of them. It's not that every time you will see sweating plus tremor plus palpitation, never like that. Sometimes only one, or maybe that also may be very feeble. Okay, sweating may be only for transient time, and otherwise the patient will recover. See, body will naturally try to recover the blood glucose level, so that symptom may not be evident for a very long time, and the counter mechanisms will activate, and it will prevent that hypoglycemia to deeply set in and go further, if that cause is ruled out, obviously.
Yes, sir. Sir, after taking sulfonylureas, what should be the timeline between which one should consume his meals?
See, as such, if you talk about the guideline says that the sulfonylurea should be taken 30 minutes prior to the meals. Okay, please remember 30 minutes prior to the meals. So please advise the patient to take the meal. If the patient has taken sulfonylureas maybe 15 minutes early or 1 hour early, that's not a big problem. But he misses the meal, then it's a problem for the patient. Then it's hypoglycemia for sure.
Yes, sir. Sir, a bit of a longer question. Is in
Okay.
the era of CGM, so and glucometers, and with a known measurement error, should
Mhm.
hyperglycemia continue be to be defined as the Fitz thresholds, or should we have the definition that incorporates the symptoms as well and the trends and the device accuracy?
Excellent question, Dr. Harini. This is something which is the hot topic of today's concern. I agree to you 110%. I agree to you. There is error. Always there will be error. Be it whether you're taking blood pressure measurement, also there is always an error of the instrument. But yes, definitely you have to club this with the symptoms of the patient. So that's why we discuss the common symptoms. So you have to ask. And plus, supposedly if you have an instrument error, that can happen once or twice, not every time. Not 100 times the instrument is error, that is not happening. And plus, the patient will also have some symptoms. If there is asymptomatic with instrument error, that can, as I told you, that can be overcome by asking the patient to test the blood sugar of the family member, obviously by changing the lancet, so that that can be caught up.
Yes, sir. Right. Um, yes. So when to take metformin and when should we take it to prevent side effects? Should we take it before the meal, with food, or after the meal?
Okay, so Dr. Narendra, correct, very important question. And metformin is the first line of treatment for every diabetic patient. So metformin should be, as per the standard guidelines, it should be taken either with the meal or immediately after the meal. It is never to be taken before the meal. But remember, nowadays we have prolonged release tablets, sustained release tablets, so you can actually prescribe, and the patient can take it before the meal also. That's not going to be causing a major shift in the blood glucose. But ideally, if you ask me, prescribe with meal or after the meal. Immediately after meal is the best time to take.
Okay. Yes, sir. And so, can we give sulfonylurea with with insulin?
See, this is a very good question again, Dr. Lokesh. Insulin depends upon type of insulin. If you are giving regular insulin, then you have to be very, you have to be very active in monitoring, and you have to be judiciously using the sulfonylureas. But if you are clubbing the sulfonylureas with a long-acting insulin, let's say Glargine or anything, so then you are relatively safer. But yes, please make sure you give low dose, maybe zero point 0.5 glimepiride or maybe 1 mg glimepiride. Don't over prescribe sulfonylureas at any point of time. I've seen patients and doctors having giving the prescriptions up to 8 mg. See, permissible as per the guidelines is 8 mg glimepiride, but don't give to that level. Stick to 2 mg maximum, or if you want to proceed, go for 2 mg twice a day, not very high than this.
Yes, sir. So we've received a lot more questions, sir. I'll take them up
No
as
problem, no
well.
problem. I'm happy people are listening to me and asking, so that they have listened this talk. I'm very happy actually.
Yes, sir. Sir, like we spoke about metformin in particular, what about the other OHs? The
Please let us
timing
know the
for
exact
OHs.
timing. Acha, exact timing of it in relation to the meal. Okay. So see, OHA, as you are mentioning, it's a very broad term now. We have a lot of drugs. So metformin, last question was yours only. So I have already told you. Sulfonylureas, I have already told you. Then if you talk about DPP-4 inhibitors, so you can actually take them any time in a day. So it can be with meals, after meals, before meals. That usually does not matter too much. Then the injectables, they are also once weekly injectable, so that is usually given before the meals to prevent certain problems, and avoid any new medication to be started in the patient at the midnight or in the night, usually because you don't know, the patient will end up into nocturnal hypoglycemia. So preferably stick to the morning schedules only if you are changing or making a subtle change in the treatment.
Yes, sir. Continuing the OHAs, a couple of questions on that. What are the safe OHAs for liver diseases? Are they safe, or are there anything
See,
in particular?
to be very honest, no medication is safe. Okay, so every time you have to see, per se, the OHA may not be the one which will be leading to liver diseases. There may be other problems like alcohol, very prominent and common problem. So you have to ask the history from the patient. Maybe there's some past surgical history or medical history. That is more important than the OHA per se. And whenever you're prescribing any OHA, please make sure you have a regular annual or 6 monthly checkup of LFT, KFT, HbA1c, and lipid profile. So that way you will not miss any important areas.
Yes, sir. Sir, a light liver, what about CTD? OHs in CTD patient?
The question is not coming. Acha. Okay, safe OHA, safe for CKD patients. See, for CKD patients, see, usually we try to limit the OHA. To be very honest and frank with you, we try to shift the patient on insulin only. That is much more safer option. But if you have to give OHA, do not prescribe metformin. It has seen to progress the CKD further to further, stages. So preferably go for DPP-4 or the latest newer therapies, the SGLT2 inhibitors. They are the best treatment, and GLP-1 RA, that is again a newer therapy. But with those newer therapies and better treatment options, the cost is the biggest option, the biggest problem. So cost is also high for all those treatments.
Yes, sir. Which insulin is more prone to give hypoglycemic events? Is it the mixed insulin or the long-acting ones with the bolus?
Okay. See, usually the mixed one and the regular insulin is the one which is causing the problems. And long acting usually does not cause problem, but this is not a practical single statement. There are other factors as we discussed in this talk. Plus, you have to ask the patient about the meal pattern. There may be a meal mismatch. Plus, there may be the insulin. I've seen such patients that you have prescribed insulin glargine, but the patient is not taking that. He is taking some other insulin he has purchased from some periphery. So you don't know, but you are prescribing something, but the patient is taking something else. So you have to ask the patient. The history is very important to avoid all these hypoglycemic events. So yes, mixed insulin can cause hypoglycemia episodes, especially when it is not given in proper proportions. So you have to maintain the proper proportions of the mixed insulin and never club different types of insulins unnecessarily. Just if you see some senior prescribing, so don't go for that. Follow the standard practical guidelines. So stick to the single or at least two types of insulin you can use. That's the maximum to do. Do not club all of them together. Don't make a cocktail actually in the patient.
Yes, sir. Sir, how should insulin be adjusted for a patient who is having fasting hyperglycemia?
Okay. So as you told, insulin. So insulin, Dr. Nidhi, is again a broad term. Insulin may be any type of insulin. So you have to see what kind of insulin is prescribed. But if you have to prescribe and if you have to change with respect to the fasting hypoglycemia, the rule says you have to think of the night. So if you have to control the fasting hypoglycemia, you have to focus on the night insulin. If you are focusing, it's just behind basically, nothing else. So if you have to control the fasting, so you cannot expect to change the dosage of the afternoon insulin. Okay, so it depends upon what you are prescribing and what is the dosage he is following. Plus, make sure you check with the OHA also. Supposedly insulin is perfect, but he is taking sulfonylureas. So then you have to focus on sulfonylureas, not the insulin per se in such a case scenario.
Yes, sir. Which sulfonylurea would have the minimum chance of hypoglycemia? Is there anyone?
This is a very questionable statement, to be honest, Dr. Bharat. See, usually glimepiride is the perfect choice, but it comes with high risk of hypoglycemia. I agree with you. Gliclazide is also there, but it is, as you see, sulfonylureas per se will cause hypoglycemia. So you have to be, make sure that you do not prescribe them if you are thinking that the patient may land up into multiple recurrent episodes. So better to avoid them. If yes, then make sure you monitor it very closely.
Yes, sir. And sir, if a oh, sorry.
I think
Mm.
these many comments were not there previously. They have added after the talk, I think so, Anna. Before,
Yes,
during
they
the
have.
talk, there
I
were
am
not many.
still accepting comments, sir, while as they come, and
I
I'm
hope
reading.
people have enjoyed. Please give a thumbs up or a smiley if people are there listening. I have more than 350 participants. Initially, there were 100, 200, 250, 300. Now they have crossed 350. So
Yes,
thank you so
sir.
much, everyone, for the love. So maybe I'm helping everyone. Any further question? Any important
Yes,
question?
sir. A lot more. I'll try to
Okay.
combine as many as I
Okay.
can.
Okay. Please do.
Yes, sir. Sir, can you please throw some light on the sick day rules that you mentioned?
This we will get back to later on, and you can skip this
Yes.
question.
So
Hmm.
something in brief we can talk about while we conclude the session. The main
Okay.
thing.
See, as a thumb rule, please make sure all of you, be it a doctor or a patient, make sure you discuss the hypoglycemia in detail. This is a lacuna in the doctor patient communication, which I have seen over the past multiple years. Usually, they don't have time. We don't discuss too many things, and hypoglycemia is something which is neglected. And the patient is at high risk of hypoglycemia if the treatment protocol is wrong, or even if treatment is fine but he's not following it properly. So both ways actually. So please spend some time, or if you don't have time, make a sheet where you can, patient information sheet, where you can share with the patient the standard protocols and standard rules which he or she can follow to avoid the hypoglycemia episodes, recurrent hypoglycemia, because that is more harmful and life threatening as compared to the hyperglycemia.
Yes, sir. Sir, in a in an unconscious patient with severe hypoglycemia and concurrent hypokalemia, which one should be treated first? What do we correct first? And
Okay.
how do you balance the glucose administration and the worsening hypokalemia?
Okay. So this will be in clinic. This will be a IPD patient if the patient is already admitted.
Yes.
So definitely potassium is important, but insulin and the glucose level has to be maintained. That is the most important thing. But yes, you have to keep a good check on the potassium levels also. So ABG analysis is very important. So every 2 hourly or 3 hourly, you have to make sure you do the ABG analysis and check both the symptom, both the levels accordingly.
Yes, sir. And sir, which of the following glucometer or uh, lab investigation give accurate results? What do we prefer?
See, neither. See, the patients will have some or the other investigation, whether a glucometer or investigation from the lab. Both can have problems. Both can have some errors. So you cannot think one report as the golden report. If you think it is in sync with the patient's case scenario, clinical case scenario, then yes, definitely go for the value. Otherwise, if you are doubtful, please advise the patient regular glucose monitoring. So usually I advise the patient for 5 days glucose monitoring, and then the patient follow-ups. So that way I am sorted. So patient, suppose if one day glucose reading is wrong also, and advise the patient, if there is a hyperglycemic episode or hypoglycemic episode, check the blood sugar after 30 minutes on the same time on the same day. So that way I have a full 5 to 6 days chart. That is the perfect and accurate result. Okay.
Yes. A proper segue into the next one. What should be the
Okay.
indicators of CGM?
This we have discussed. This is we have
Yes.
already talked about. Yeah, we covered it.
Yes, sir. Uh, Moving on to there are a couple of more questions.
Okay.
Uh, Sir, are there any specific or preferred fast acting glucose or
None as of
carbohydrates that we
none
should
as of
take?
I'm aware. No, none as of.
Yes, sir. Uh, and So this is one question that has come couple of times in the
Okay.
comment section right now. Is if
Okay.
a patient we have prescribed a medicine to a patient and they suffer from hypoglycemia after prescription, and can
Acha.
it lead to a medical lethal case?
Not so likely. Actually, you have to, be smart enough to tackle such cases. I should not be saying this on the public platform, but ideally you should avoid this. But if it happens, then you have to be smart enough to discuss. Then maybe you are not at fault. Maybe your treatment and everything was not at fault. There was some other factor which caused the issue. So do not blame yourself blanketly. You, as a doctor, we all take Hippocratic oath, so we will not cause any injury or harm to the patient. Neither you will nor that I will. So please remember, don't take yourself as guilty. There may be some other problems. Investigate into the cause of the problem, and then you can, further discuss.
Yes, sir. A last few questions, sir.
Okay.
At sometimes the postprandial blood glucose is lower than the fasting in a
Hmm.
diabetic patient who is
Hmm.
on
Hmm.
OHs.
Hmm.
Is that what does it lead to, and
See,
what does?
usually that is like many times there is error in the reading, and many times there is a problem in the treatment regime. Sometimes the treatment, the medicines which or insulin which were given, they are given wrongly at the wrong time the patient is taking. So those things have to be discussed and managed to avoid such interpretation.
Yes, sir. And among the glitazide, which
Hmm.
form is better? Is it the plain form or the extended one dose?
See, plain and extended both are, again, as I told you, it belongs to the same class only, so it will cause hypoglycemia. So, avoiding hypoglycemia, you have to avoid altogether the entire class of drug, because you have multiple treatments. See, it's way back 10 years back when you have no other options. So, you had to prescribe gliclazide, glimepiride. Nowadays, you have multiple other options. Why you want to stick to those old treatment regimes and uh, you know uh, have that concern of hypoglycemic episode? So opt for the newer treatments.
Yes, sir. And so, sir, one last question, sir.
Hmm.
How commonly do you use octreotide injection for prolonged sulfonylurea, which induces
I
hypoglycemia?
am not using it because it's very costly. I want the patient to be easy on pockets. He will not come to you back again.
That's fine. Thank you so much, sir. That brings us to the end of Q&A. Thank you
Okay.
so much for taking
Okay.
such a
Thank you.
lot of questions from our
There
audience.
were. I was not expecting, but maybe I'm helping those people. We have more than 350 participants.
Yes, sir.
And thank you, Dr. Sanika. Also, I should the one who is thanking her. Also, she has calmly read all the comments and she has, gathered them, clubbed them, some of them, and helped to discuss them in a short span of time. And for
Thank you,
the
sir.
wonderful conduction of this webinar. Thank you so much.
Thank you so much, sir.